Hi, I'm really sure that almost every one of you who gave NEET MDS 2020 are eagerly waiting for the key. See, based on the keywords which you're giving us, we're working 24/7 in order to produce as many videos as possible, incorporating as many topics as possible. So we'll keep working 24/7 to get things done, and I would really appreciate your support in this journey. And also, as I mentioned prior, it's not just about providing you key, but also to focus on the topics so that those who are aspiring for 2021 will have an idea like what topics were covered in the recently concluded exam, right? So we'll start with the following topics in this particular video: concentricity and runout, which we discussed in our e-classes as well as study club discussions. So if you look into the literature, concentricity is a direct measurement of the symmetry of the burr head itself. It measures how closely a single circle can be passed through the edges of all the blades. Concentricity is an indication of whether one blade is longer or shorter than the others. So it's a static measurement, not directly related to function, which is very important. Runout is a dynamic test measuring the accuracy with which all blade edges pass through a single point when the instrument is rotated. It measures not only the concentricity of the head but also the accuracy with which the center of rotation passes through the center of the head, right? So just keep these terminologies in mind and also try to have a deep understanding pertaining to these topics. And there were several questions asked from concentricity and runout in n number of entrances, right? So consider this topic very important. Now let's move on to the next question. Fenestration dehiscence. We had an image based question in our test series. We discussed the same in our e-classes. So if you observe literature, and also as you can see in the image, we have fenestrations and dehiscence. You can see dehiscence in relation to canine and fenestration in relation to first premolar. So isolated areas in which the root is denuded of bone and the root surface is covered only by periosteum and overlying gingiva are termed fenestrations. In these areas, marginal bone is intact. This is very important. So when the denuded areas extend through the marginal bone, the defect is called dehiscence. And also make a note of this point that such defects occur on approximately 20% of the teeth. So we have seen this latest trend in exams where they're asking even the percentage incidence. So it's better you memorize these values as well, 20% of the teeth. Now, moving on to the next question. What are the causes of xerostomia? I need to extensively review literature and refer me various articles in order to get some useful and valid information relevant to the causes of xerostomia along with Schaeffer's. So as you can see, we have different causes. First, we'll go through the literature given in Schaeffer's. So we have various temporary causes, permanent causes. Also you can see radiation can lead to xerostomia. Also in case of diabetes and other systemic disorders, there can be xerostomia. What about hypertension? See, in one of the articles it's clearly mentioned that there are no recognized oral manifestations of hypertension, but antihypertensive drugs can cause side effects such as xerostomia, gingival overgrowth, that is amlodipine as you know, and various other anomalies, right? So consider this very important. So this is pertaining to hypertension. Now what about elderly patients? See, if you review literature, although xerostomia is associated with aging, studies have determined that salivary gland function is well preserved in healthy geriatric population. Therefore, dry mouth is probably not a condition of aging, but most likely one of the systemic or extrinsic origin, right? Saliva seems to undergo chemical changes with aging. As the amount of talent decreases and mucin increases, saliva can become thick and viscous and present problems for the elderly. One of the most prevalent causes of xerostomia is medication, including anticholinergic medication, antihistamines, psychotropic agents, diuretics, etc. So review this literature and see if this is helpful for you in answering the particular question asked in exam. Okay, now let's move on to the next question. Image-based next question on soil transmitted parasites, hookworm. You mentioned about some parasitic infections, right? So if you look into the images which are being posted now, so there are different and several soil transmitted parasites. Also you can find extensive information in WHO website. So the first one is roundworms, which live in small intestine. They can grow to over 200 millimeters in length. If there are a lot of them, they can obstruct the bowel. And we have whipworms, which are about 40 mm in length. A heavy infection with whipworms may lead to abdominal discomfort and diarrhea. And then hookworms, also they are about 10 mm length. A heavy infection with hookworms can cause serious illnesses. Children develop malnutrition. Adults, especially pregnant women, can become seriously anemic. Along with that, you can also find additional images pertaining to these parasites, right? So check out which of the following images was given in exam and see if you can identify them accordingly, right? Now moving on to the next question, tubular reabsorption. So if you review literature, tubular reabsorption, so what does it mean? So as the name itself indicates, it's a process by which water and other substances are transported from renal tubules back to the blood. So when the glomerular filtrate flows through the tubular portion of nephron, both quantitative and qualitative changes occur. Large quantity of water, around 99% or even more than that, including electrolytes and other substances, are reabsorbed by the tubular epithelial cells. So the reabsorbed substances move into the interstitial fluid of renal medulla, and from there the substances move back into the blood in peritubular capillaries. So since the substances are taken back into the blood from the glomerular filtrate, the entire process is hence named tubular reabsorption, which is obvious. And also make a note that about 7/8 of the filtrate, that is about 88%, is reabsorbed in PCT, proximal convoluted tubule. The brush border of epithelial cells in PCT increases the surface area and facilitates reabsorption. Substances reabsorbed from PCT include glucose, amino acids, sodium, potassium, calcium, bicarbonates, chlorides, phosphates, urea, uric acid, and water, right? Now let's move on to the next question, iliac grafts. So if you review literature, which part of iliac graft is commonly employed and what is the reason? So cancellous bone graft material is most commonly used iliac crest bone graft, that is ICBG material. The surgical techniques for ICBG harvesting all involve extraction of bone graft material from either the anterior or posterior iliac crest. The most commonly used site for harvesting is the posterior iliac crest, partly due to large quantities of potential bone graft material which is available, right? Now let's move on to the next question, graft for orbital floor reconstruction, which is the most commonly used donor site, right? If you review literature, in case of reconstruction of orbital floor, you have the following materials available, and autologous materials. So bone grafts for the orbital floor have long been considered the standard treatment for orbital fracture repair. Donor sites include split calvarial bone graft, rib, maxillary wall, mandibular symphysis, iliac crest, antral bone, and coronoid process. And also we have cartilages which can be used as donor tissue. So another frequently used source of donor tissue for orbital floor reconstruction is cartilage. The more commonly used autologous cartilage grafts include nasal septum, rib cartilage, and ear cartilage, right? So this is some literature pertaining to this question. See if it is useful. If you need any additional information, do let me know. I'll update that in the description part of the video, right? Now let's move on to the next question, gold based alloys. As you know, there are 4 types if you review literature given in Phillips. So type 1 gold alloys, they are soft and designed for inlays supported by teeth and are not subjected to significant masticatory forces. Type 2 alloys are widely used for inlays because of their superior mechanical properties, but they have less ductility compared to type 1. Whereas type 3 alloys are used for constructing crowns and onlays for high stress areas. Increasing the platinum palladium content rises the melting temperature, which is beneficial when components are to be joined by soldering or brazing. Type 4 gold alloys are used in high stress areas such as bridges and partial denture frameworks. The cast alloy must be rigid to resist flexure, possess high yield strength to prevent permanent distortion, and be ductile enough for adjustment if the clasp of a framework has been distorted or needs adjustment. So these are the 4 types. So look into the question again, and if you need any additional information, do let me know. Now moving on to the next question, disadvantages of meshed skin graft. So if you review literature, what is this meshed skin graft? Split thickness skin graft can be meshed to expand. So when the defect to be grafted is extensive or has convoluted surfaces, split thickness skin grafts can be meshed to expand. So this meshing process not only increases the surface area that can be covered by the harvest graft, but also allows the graft to adhere better to a convoluted wound. So the disadvantage of meshed grafts are wounds with a checkboard appearance, which leaves an aesthetically less attractive scar and the possibility of causing more contraction of the wound, right? So just look into this literature again. If you need any additional information, do let me know. Now moving on to the final topic, parasitic infections. We discussed in our study club eosinophilia. So observe this table, you will find various conditions where there can be eosinophilia, including hookworm, loa, trichinella, etc. right? And also you can find the fact that there can be non-parasitic causes of eosinophilia as well, which include hematological conditions, allergic reactions, HIV-1, human T-cell lymphocytic virus, etc. right? Along with that, in tropical or travelers to tropical areas, there can be eosinophilia associated with parasitic infections, particularly helminths. So anybody with an eosinophil count more than 0.4 into 10 power 9 per liter should be investigated for both parasitic and non-parasitic causes. Also remember, eosinophilia is not a typical feature in malaria, amoebiasis, leishmaniasis, leprosy or tapeworm infections other than cysticercosis, right? So these are some of the topics which I wanted to highlight in this particular video. So I hope this reviewing of literature is useful for you, and as I mentioned, if you need any additional information, I'll definitely update that accordingly in the description part of the video. And for previous videos as well, I just uploaded some additional information in the description part. Just check it out and let me know if you need any further assistance, right? So wish you all the best, love you all, and I'm really hoping that you're having a great time. Take care.